Thank you. Good morning. And thank you for including Skills to Care as part of this fascinating dialogue so far. So Skills to Care is one of about 4 or 5 interventions that, I'll call it interventions at this point, because it's in the randomized trial format, that I developed with my colleagues when I was at Thomas Jefferson University. And Skills to Care specifically was the Reach One Philadelphia site, and it was known as the Environmental Skill Building Program in the scientific literature. And of course, one of the first things we learned through the translational effort was the name, and naming and framing, and who really wants to have the environment of their home tampered with. So we really needed to come up with a different name, and that's what we did. So let me explain a little bit about the program itself, and then I'll go on to its translation, the translational efforts, and talk a little bit about some of the hurdles and successes. So this is a program that does target people at the mild, moderate to moderate severe dementia stage and their family caregivers. I think it's important as we think about the wide range of interventions here, where do they all have merit, and where do they fit in terms of the continuum of care. It is home-based. It's delivered in the home of persons with dementia who are living with someone with a family member, or in which the family member lives within a 5-mile radius close by. It is delivered by occupational therapists who have to be trained in our program, and we do have a certification requirement. And it is delivered by occupational therapists because they bring, by nature of their training as occupational therapists, an understanding of how quickly to assess the physical and social environment of the home, as well as the physical capacity of a person with dementia, which becomes very critical pieces of information that is imparted to the caregiver. From the randomized trial phase, we purposely built in a very flexible visit schedule so that our protocol was very flexible, and I mentioned that as a delivery characteristic that then allowed us to translate this particular program into different kinds of settings. So the schedule involves basically 6 to 10 sessions. Anywhere it can be truncated into 2 months and spread out over 6 months, again, depending upon the requirements of a funding environment. Each session is anywhere from 50 to 90 minutes, and again, they're scheduled flexibly over the period of time of the intervention based on a whole range of considerations. We typically find that we can manage about 3 to 5 caregiver-identified problem areas. This is a very client-driven approach where families, we systematically go through a needs assessment with families. They identify the most kinds of challenges that they're confronting, and then we go through what many of the other interventions have already mentioned, a problem-solving process that became very specific as well to Reach 2 that you will hear about. So some of the problem areas that we typically address have to do with how to manage functional decline, increasing dependence of the person with dementia, and how that may impact on the caregiver's own well-being, anywhere from back protection to how to successfully involve the person with dementia in very basic activities of daily living. We focus a lot on problem behaviors, how caregivers can coordinate care among other family networks or their support networks, and we have a whole unit on taking care of themselves, and then how to involve not only others within the family, but also how to talk to their doctor and other health providers. So we have a range of strategies that are provided, and everybody gets these strategies, but then they are tailored to the particular problem areas of the family member. So they receive basic education, which is ongoing about the disease. You know, a typical comment from a caregiver is, you know, he's not dressing to spite me, or he's acting out, in quotes, because he just wants to get back at me. So we do a lot of education. We, again, do problem solving and model that and instruct in that as a technique, because we're obviously only there for up to 6 months and the disease may progress out to 4 or 5 years. And so the whole point is to build skills. How do you think about your physical and social environment, how that's impacting on your ability to provide care, and how that's impacting on the person with dementia? What kinds of environmental changes may be helpful, including the use of assistive devices. We specifically recommend and help caregivers set up very structured routines throughout the day for a person which is very successful in whatever stage they are. Now, we have a number of papers that have been out that address skills to care and that build on it. Because our main outcomes have been successful for both caregivers and people with dementia, that has been an added plus in terms of the translation. So basically, in the 2003 the Gerontologist, where all the REACH 1 interventions were showcased, we reported that the intervention improved caregiver well-being, it improved their skills, we measured skills, it enhanced their confidence in caregiving, they were less upset with behaviors. And in subsequent papers from that data set, we found that we also could reduce behavioral symptoms, and we could reduce functional dependence, and we could improve activity engagement. So that has been reported in various papers. So I want to now show you that a range of mechanisms that we've been able to translate skills to care, and we've been, as everybody does, struggles with, the whole issue of sustainability. So through funding from a whole range of sources, including the Administration on Aging and the Rosalind Carter Institute and so forth, we've been able to translate skills to care for delivery through the National Family Caregiver Act through AAAs. We've also been able to integrate skills to care into patient care and have occupational therapists and home care agencies be reimbursed through Medicare Part A and Medicare Part B. Now, I have to be clear that we did not change CMS policy here. It's not that we got additional codes. Sometimes I get emails, people are very excited, how did you change policy here? And that is just not the case. It is part of Medicare practices in A or B for patients to provide caregiver education as long as it relates to the functional skills or with the skill program for the person with dementia. But healthcare providers in home care agencies are not trained, as our previous morning discussion revealed, in any kind of evidence-based approach or even how to talk to a family caregiver. So what Skills to Care does is it provides a very systematic assessment forms and approaches so that the occupational therapist who's providing some kind of skilled care to the patient with dementia, I'll say patient because that's what they're called in home care, they can then systematically identify the caregiver's needs vis-a-vis the person with dementia and provide them with important skills. And we have demonstrated through a variety of funding sources, Rosalind Carter and some private foundation monies, that we are very successful in having agencies get reimbursed in this mechanism. So this is a very important mechanism that is under-tapped. Also, before I left Jefferson, I worked with colleagues to develop our own service setting so that we're Medicare Part B certified. So we have Medicare Part B certified interventionists who now have integrated Skills to Care as part of a much broader program of dementia care services that maybe we'll talk about. The other approach that we have used for Skills to Care is private pay. There are people who want to have consultation. We've delivered it, again, in a very flexible manner over the phone. People come into the office or at home. And we're now seeking to look at other kinds of settings, and we also see Skills to Care as a very important mechanism for transitions. Transition, for example, we could see somebody in a Med A, an immediate home, they're homebound and have an acute problem, and then they need more therapies, and then they are sent over to Med B, and Skills to Care could be picked up in either one, or from discharge from hospital. So I'm not keeping track of my time. I hope somebody else is, but I'm just going to go on if no one pulls me off, okay? Okay. So I just want to point out that some of the challenges and barriers, I think that we've been successful, pardon the word, of exploiting, the current policies of Medicare, and it does fit in, and there has never been a problem with getting reimbursed. But here's the problem. If the patient reaches their functional goals, they have to be discharged. But the caregiver has many more unmet needs. So there is a serious limitation, and I think that's a clear policy implication of what we've been trying to accomplish here. It would not be, we're not talking about for the rest of their lives. We're talking about 2 to 3 or 4 to 5 more sessions that would really make a difference in the person's life. So we're also dependent on physician prescription for an OT eval and assess. So what does that mean? That means that we have to do a lot of training, and the home care agencies that we've been training have to in turn have a lot of training of their physician referral group that they can refer for a patient that has dementia for which there's a safety and functional decline. So people that are seen in home care now in any of these mechanisms are not necessarily seen because of the diagnosis of dementia. Obviously, it can't be denied because of a diagnosis, but that's not why the referral was made. So we think, again, that through an education process, we could really open the doors here by, if physicians understood that with a diagnosis of dementia where there is a concern for functional decline or home safety issue, that skills to care can really play a very significant role. This is a skilled intervention. We're really struggling, as the early panel was. I mean, who's right? Are they, how much training and education does a person have? And it really comes down to, Susan, what you said, and I think somebody else said, interpersonal skills, ability to be a flexible thinker. It doesn't even matter, we've discovered through our translational efforts, the number of years in home care or with exposure to dementia. It's a basic set of skills that really all health professionals should have, but occasionally there isn't a good match. I just want to say that, so the marketing and we have an economic model, and I do have a brochure that explains that for home care agencies, because the biggest issue of adoption by home care agencies is we have to propose a value proposition. And they get reimbursed. These agencies get reimbursed immediately. We have to take their therapists out of the clinic of their home care for 2 days. And the therapists do have to be trained through readings prior to that. But then, as part of their coaching stage of training, they're seeing real people, and the agency gets reimbursed immediately for that. So there is no loss to the agency, and they also have set aside time, monies, I should say, for continuing ed that I can't read from there because I didn't bring my glasses. 1 minute. Okay. I'll talk really extra fast. So they have extra monies for continuing ed. So this has been, from an agency perspective, a win-win. Nevertheless, my goal would be to have every single home care agency be trained, and this is agency by agency by agency. And so, I'm not, it's 17 years from the IOM. How many more years, do we all have here? How many, 17 more years, So, and then I guess I want to say that this is, sorry. Also I think there's some real challenges in translation. How do we integrate new evidence and better approaches? We've gone way beyond skills to care. Skills to care is now embedded in a much larger dementia care program that we've been testing. So how do we get that out in a meaningful way? And the other question that I would like to raise is, who should own evidence-based programs? Do universities own it? Do investigators own it? Should there be a central clearinghouse? And a very good example of that is, I left Thomas Jefferson University. I was there, I trademarked this at Jefferson University. If Thomas Jefferson University doesn't see the value of continuing this, then what happens? So I think this is a big issue in the larger scheme of things as to where and who should be doing these things, and how can we allow for the evidence to be sustained in a meaningful way. Thank you.
Our next speaker is Dr. Mary Middleman, and here is your presentation.